And you are talking about technique, details of this, right? And after the technique, you're doing planting or different, different, which is the plant of.
So this is what I did, a complete hydrodissection. And
They have doing
yeah, active also after I rotate the nucleus. So, so you can see that well. So this is very important because you start any kind of a chopping technique. इसको अभी वो दे दो मुझे हाँ, बस ठीक ठीक हाँ, दे दो, इसको दे दो. It's okay now. So you have to pull this sleeve a little more because you want this the tip to be exposed at least 1.5 to 2 millimeter because you have to get the hold of these hard nuclei. सीधे देखो बाबूजी. And this is the chopper I'm going to use. This is a Terminator, an specially designed chopper for this kind of cataract. So I'll be just cleaning the some of the socket chop. Hmm. So I'm going. I've gone to the chopped setting now, and I use vacuum around 470, 480, and fluidics flow rate around 34. So this is how you have to go from the center, impale the nucleus, and take it towards the periphery. Hold the nucleus here, draw the nucleus a bit, and ये थोड़ा सा नीचे करना sister. वो एक्चुअली में वो आ रहा है मेरे सामने ना क्या कहते हैं इसको. So this is how I hook it, and you crack the nucleus here. So a small crack has happened, not the full crack. I'll just go from the saline. साकेत टिप कौन सा वाला है? What tip is given? साइज क्या टिप है? साइज क्या टिप है? So sometimes you have to go around and try to do the chop at multiple places. Very hard. This one is a very hard nucleus. Now you see the endonucleus is
Hello.
almost like a ball here. You can see this. So I'll take the endonucleus first. Just complete the emulsification of this one. It's setting सही नहीं दे रखा इसने मुझे यार. तुम्हारी ये सेटिंग जो है ना कौन सा दिया साके तुमने क्वाड्रेंट में? So see the nucleus actually, because the posterior plate is what you get the trouble. But here you can see the posterior plate is broken, but I'll have to do a complete separation. So from this side, I've completely separate. The first complete separation of the nucleus is very important. So if you get a complete full thickness separation from the center, so I'll just try to bring out one segment and do a sub chopping. So I have this piece now free. So I'm holding. Now almost since all the pieces were separate, so you can very easily bring them out and emulsify at the pupillary level. So this is how you can see the nucleus emulsification is almost complete now. And now I'll go to the happy nucleus mode now. Saline system. Light देखो light बजी. So so very little cortex is left now. I normally use bimanual only for the aspiration of the cortex, and this is my preferred technique. I don't use the coaxial. I normally use bimanual because it becomes very easy to remove the cortex with the help of the bimanual technique. लेंस रेडी कर दो, उसमें डाल दो विस्कोस को सब. हाँ. Power I normally use 40 to 50, and for quadrant I have used 40, and for holding these hard nuclei you need a little more power. I was using 50, and my aspiration rate was 34 to 36. Vacuum was around 500. लाइट देखो वापस भी, ठीक। So this is how you can see the injector now. This is what, and it's a preloaded lens. You can see the lens is already, yeah, and the tip you see this quite long tip, so you don't have to do the wound assisted. You can go inside and then inject the lens inside the bag itself. And the best part of the lens is because this lens is one that monofocal lens which gives you an intermediate vision also. Saline. And you predict actually because you don't have to think that whether the intermediate vision will come or not with this 99% of the मुझे वो दे दो, saline. So Rajesh, anything you can't ask about the lens? Like, yeah, it's basically aberration, spherical aberration based IOL. There is a manipulation of the spherical aberration on the surface of the anterior surface of the. And as you have seen, the injection system is beautiful. Lens is hydrophobic lens and beautifully incarved lens. The surfaces are beautiful and the the edges are square, C loop.
Thank you, RP sir, for such a lovely demonstration of a hard cataract.
Thank you.
Can you please shift to OT2?
Yeah.
Transmission to OT2, please.
Yeah. Give me my manual then. I'll just take out that also. Yeah. I could see now.
Can you please have transmission from OT2?
Hello. Hello. Rajesh, can you hear me? Rajesh, hi, Namrata. So I think they've moved the signal to my OT, so I'll start. I'm planning to do this lady. She's got, yeah. I use 100% intracameral moxisprox. No, I use intracameral moxi for all my
Ah, Acha, you're going to operate here, no? Good.
Hello.
No, I have to go for the inauguration, like the building. Not order. I'll see your surgery there himself.
Am I audible?
Trees by there. और how are you otherwise? Good. तो आप शिफ्ट कर रहे हैं सुना है इधर? Very nice यार. चलो रोज मिलते रहेंगे.
So,
आधा मिल जाएगा.
Rajesh,
That's good.
my patient is
Nice. Good.
49. I think Dr. Raj, उनका राजेंद्र प्रसाद का mic on है.
Right. See you then. See Sheetal. Okay. Right.
Yeah, so they'll just switch off the audio from the other OT. So my patient is a 49-year-old lady, bilateral cataract. This eye was finger counting 3 meters, improving to 624. She has astigmatism of about 0.76 diameter diopters at 14 degrees. So we are planning to implant geometric toric lens. I like to use toric whenever I need to, even with very small astigmatism, I don't hesitate to use a toric lens. So here we are going to be using a 1 diopter toric lens and a plus 22, and this is a geometric lens. which is a new generation Hoya lens with the same injector system. It's a beautiful injector system, and it's a state-of-the-art lens, which either a T2 or a 100, depending on whether I'm using a Technis or a Hoya, I will use the lens. If it is not showing it, then I won't use it. So effectively, even sometimes with the point 0.5, I will use it, and in the vertical meridian, if it's like 0.75 to 1, I may not use it, depending on with the rule or against the rule. So we do toric calculation for all patients. Yes. Point 0.1 I use for my calculation. Point 0.1. Right. I used to use point 0.3 like about 7, 8 years back. Then Dr. Barrett convinced me that if my incision is 2.2, I should not be using point 0.3. And that made a huge difference to my results also. So I'm using a 2.2 incision. And of course, center for site arrangements are impeccable. Dr. Raghav is looking after in the absence of Dr. Maipal today and doing a great job. So mine is a biplanar because I don't make a groove. I go in straight and then I dip. So it's a 5 millimeters. In fact, I've gone a little outside my mark in one area now, and it helps you to remain in place and get your right size and the right shape and the right centration and the right overlap as well. So in many ways, when you're doing premium IOLs, it helps to ensure that your rexus is rightly centered, right size, right shape as much as you can. For some reason. Okay, so let's see here. So the thing is, with other syringes like Dispovan and all, it comes with a jerk, not like the glass syringes where you're used to, it going in seamlessly, like, predictable push on the plunger. Anyway, it went now. So we're all set. I'm using again a signature machine here, and of course, okay. So here goes. This is not a hard cataract really, so I'm hoping that I'll be able to crack it and chop it. It's a fairly soft. She's a young lady, 49-year-old. So when it's a very soft cataract, it makes sense to chop right in the middle. If you try to chop in the periphery, you won't. It'll just cut through. So when I'm doing a softish cataract, I like to initiate my central chops because that's where the nucleus is a little firm. Yeah, it is a PSC. Yeah. Actually, for these patients where I don't really need to switch the mode, where I need to get into the quadrant removal, then I'll just switch it, because when you need more flow and so I'm going to use these customized bimanual IA systems which are sandblasted and made 22 gauge, except that I did not have 22 gauge knives again. So I've tried to make a 22 gauge side port with the 20 gauge MVR. So let's see. It's mostly non-leaky still. So I've been a fan of bimanuals right from the day I started doing Phaco's, which was way back in 98 or something. At that time, they never used to make bimanuals actually. We used to use our own customized like bimanuals from Gen Metal or something. So the good thing is, if you'll notice here, my infusion is going just remove it very effortlessly without having to kind of go aspirate it. You can just, I call it as a hydro jet polish or whatever you want to call it. So now I'm going to inject. So I think Dr. Rajendra Prasad already showed you the injector system. It's an amazing injector system. I think it's the best in class. Becomes very predictable, and frankly, any patient with requiring, the good thing is when you do a hydroimplantation, you have no visco to remove. So no visco is trapped behind the lens, and your chamber remains stable at all times. And the lens centers beautifully. It's one of the very nicely. I'm using my bimanual only to rotate it. I mean, he gave me that. I usually prefer to use a wide tipped spatula, but he gave me the my aspiration thing, so I just used it. ये क्या है इसमें? ये वो I know it's very finely sandblasted, so I don't normally use it. I normally would use just a wide-tipped manipulator, and that can damage the lens. But here I was just careful not to touch the center of the lens. And now my infusion is on. My chamber is well formed. There is no fluctuation in the chamber. And using my left hand to support the globe, see, I can support the globe very well. And my chamber will remain stable throughout. I'm going to hydrate first the one side port, and then my main incision. This is a geometric. Can we check the box again? Can we check the box whether it's a geometric or a geometric plus? I kind of remember it's a geometric only. Yeah. So the geometric plus, is a great lens too. I'll tell you how I decide whether to use a geometric or a geometric plus. I would normally implant a geometric for my most of my patients, unless there are some patients who are insisting that they want better near vision. Otherwise, I'll just implant a geometric. And if after the first surgery patient is happy, I'll go ahead with the second implant also as a geometric. But if the patient feels that he would have slightly better near vision in his second eye, I will go to the geometric plus, which gives slightly more light to the near rather than to the distance and the intermediate. So the two lenses are pretty similar and pretty good. Both they give good vision at all ranges. इसको थोड़ा सा fluid और दे दीजिए. And they work beautifully well for distance, near and intermediate. But if some patient desires slightly better near vision, so a mix and match is very easily possible. And since they are identical lenses in every other way, they do a very well as a combination. And you could actually use geometric plus in both eyes also, if you want to use it as if you want to give better ability for near than distance, if some patient is demanding it like that. Or you can mix and match, or you can you have to just, I think you don't have to tell him the choices, Rajesh. Most important thing is don't give him the choice. You just assess yourself what does he want, and then you decide for him. I would not tell the patient that I'm going to use this, the price is the same, everything is the same. I think I would keep that decision to myself after assessing what the patient's visual needs are, what his occupation is, what his expectations are, and then I can kind of do this. If you start telling them, then it become more confusing, I feel. So you can see that the lens centers beautifully. Only one. So I've done very few numbers. Huh. I have just 5 or 6 patients. Only one of them I had to put geometric plus in the second one. And that too, the patient did not complain. That was my assessment that his. So I think I'm done.
Thank you, Gaurav sir. That was a lovely case presentation. Can we please have the screen to from OT1?
Okay, guys. So I think we are moving to OT1. Thank you so much, and thank you for inviting to DOS. Grateful. Thanks. Thanks, Rajesh.
Can we please have the stream from OT1?
Dr. Namrata, I think you're still not audible there. Huh? 62 बना दिया 26 गेज पे बना मेरे को ना एक स्टेनिंग दे देना ब्लूरेक्स दे दो बेटर क्योंकि ना वो वाइट है बिल्कुल सेंटर में बेटर टू स्टेन ग्लो बहुत कम है मैं ना रेट्रो में भी देखा था ग्लो इज नॉट सो गुड सो बेटर टू स्टेन हाय कर सर्जरी हाँ डिड यू शो दैट इंजेक्टर वगैरह खोल वोल के नहीं 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 मैं नहीं लगाऊंगी वो खोलने वाला नहीं सेलाइन डाल दीजिए
ऑडिबल मैम
डाल दिया ना नहीं बहुत थिक है आपका भी इसको ये ना पेशेंट की आई वो हाँ ओके आई कैन नॉट हियर एनीथिंग अच्छा वहां से मुझे तो यहाँ से सुनाई देगा यस मैम गुड आफ्टरनून मैम कैन यू हियर मी ओके हाय मैम हाय राजेश सर good afternoon everybody and welcome to this live surgery session relay from Center for Sight. Very excited to be in this world class state of the art OR facility. Missing Mahipa sir here. And I would really like to thank the organizing committee of Delhi Ophthalmology Society, Professor Bhalla and Professor Rajendra Prasad, and Hoya Surgicals for giving me this wonderful opportunity to showcase a surgery in this live surgery session. And I will be demonstrating a case of phacoemulsification with the implantation of the Hoya Vivinex Impress in the depth of enhanced monofocal from the Hoya company. And is it clear now? Okay. So my patient today is a 62-year-old male and his IOL power is plus 19.5 diopters, slightly myopic, and his set is well dilating and he has no comorbidities. So I'll be starting with the case now. Sir, light mein dekhiye. So I'll be talking about the lens and its technology as we go along. So I'm using a 2.2 millimeter keratome here, pen blue, anterior capsule. And I would like to wait for at least 10 seconds. Saline. सर लाइट में देखते रहिए प्लीज बट आई थोड़ा वॉश कर देंगे
यस मैम
I'm putting some visco to form the anterior chamber. So as with all the other lenses, centration of rexis and a well-sized rexis is very important with this lens also. But fortunately, with this lens, a decentration of up to 0.7 millimeters is tolerated well. Nevertheless, it's always good to have a well-centered and well-sized rexis. So I'm aiming here at a rexis size of between 5 to 5.5 millimeters. सीधा देखते हैं, आंख नहीं हिलाइए. Visco, please. So we are not coming. It's oh. Sonia Selai. It's a looking little dense scattered in the center. So I'm trying not to make a very big rexis. Trying to keep it as round as possible. Okay, so I think it's a decent size. That's cute. So very gentle hydrodissection. And you can see the posterior wave and rising of the nucleus. And I'll be gently rotating the nucleus. Okay. So I'm using the Signature Pro phacoemulsification system. And my parameters are sorry, sir? No. Okay. लाइट में देखिए सर. सर प्लीज लाइट में देखिए. थोड़ा नीचे देखिए सर एक बार. आई विल बी मेकिंग माय साइड पोर्ट. So I use a direct chop method for nucleus disassembly. Sir, light में देखते दीजिए. The tip has to be exposed a little bit more here. I'm using the straight tip. The gauge of the tip is 21 gauge. Sir, light में देखते रहिए. So I like to aspirate the superficial cortex that improves my visibility. My phaco power is 40, vacuum is 500, and aspiration is 42. That's the direct chop. And I've divided the nucleus into two halves, two heminuclei. And since it doesn't look like a very hard cataract, so I'll just make 4 quadrants. For harder grades of cataracts, I like to make at least 6 or sometimes 8 pieces as well. So I'm done with my sub chop. Change the setting, please. Quadrant. In the quadrant mode, my vacuum is 570. Aspiration is 42. And power is 40. Power is 50, I believe, no? 40. पढ़ा दीजिए power, please. Yeah. So you can see the excellent followability and chamber stability with this system, and mainly because of the use of small bore aspiration tubing which they use in this machine that prevents the surge. Okay. Yes, ma'am. I'm using this machine actually after a very long time, 1.5 years, but I'm still very comfortable using it. The chamber stability is excellent. Even though I'm using a 2.2 tip here, there is no shallowing of the chamber. But for the last piece, I would like to reduce the parameters. So I've shifted to the epinucleus parameters. Come hai, isko चाहिए, please. Please increase the vacuum a little bit. Yeah. Just to be on the safer side. Cornea saline, please. Thank you, sir. Okay. So I'll be implanting the Hoya Vivinex Impress Enhanced Monofocal IOL. We are using this IOL now since some time and really some great results. Light में देखिए sir. So I'm using this IA cannula for yes sir. I'll be discussing the technology when I'm implanting the lens. So there's a bit of stringy cortex here. Please give me hydro polishing. I think it's actually this 2.2 is there. So the use of this injector is very easy, and I think it's one of the best injectors I've ever used because it's quite surgeon and wound friendly. It is compatible with 2.2 millimeter incisions. So the width of the injector here is 2.2, and the width of this nozzle is 1.7. So it is quite easy to implant, and there's absolutely no distortion of the wound. स्लाइड देखिए सर, स्लाइड में देखते रहिए सर, स्लाइड में देखिए, and you can see that even though it comes out of a 1.7 mm nozzle, the unfolding is quite smooth, does not open up, it does not take long time to open. Some of the other hydrophobic lenses come out of a 2.2 injector are very slow in opening. And also, I hope you could appreciate the textured haptics on the haptics. Yeah, the haptics are textured, so that's a big advantage for the toric models for rotational stability. Yes, yes.
Paucity of time.
Yeah. So, so I would just like to, for 2 minutes, talk about the property of this lens. So as you can see, there are no rings on the surface of the lens. The surface of the lens is very smooth, and how this lens works is basically in 2 millimeter zone, they have, so the curvature changes, and due to which there are changes in the power also in the micro 2 mm zone. So that then the depth of focus.
Do you have OT2?
देखते रहो ऐसे झटका नहीं देना है Yeah.
आपको ना
Good afternoon. Greetings from Center for
clear
Sight
कर
team. Yeah, going to operate
चला
in this patient, 60 years female, no comorbidity, and new 223. I'm going to put a Hoya geometric trifocal lens. Yes, ma'am. Hello, Namrata ma'am.
Yes.
I will attempt CCC of around 5 or 5.5. माजी आप लाइट को देखते रहना है ठीक है So yeah, I'm attempt. Yes, a direct job. My settings are around 450 vacuum, 42 aspirations, and bottle height is around 80, and power is 40. Yeah, now I'll shift to quadrant. The settings will be almost same, except the vacuum, I will increase it by 50. So now the vacuum is around 500. We are planning to put Hoya geometric trifocal. Epi, please.
Happy.
Yeah, but you could see the how beautifully the lens delivers, the beauty of the delivery system of Hoya. So, and it's very surgeon friendly. They have all the options whether to push or rotate, and the plunger length can also be adjusted. Yes, ma'am. We do. We mostly in all cases preferred. Yes. Yes. The exposure time reduces significantly, so the chances. Yeah. Yeah. Yes, it does significantly. Yeah. Thank you. Thank you, ma'am. Huh? Have you named? Thank you. वो नीचे सिर्फ अब माइक हटा दो थैंक यू अभी वो डॉक्टर क्या